What is SFOT? I don't know.
Girl job.
Dr. Nuaz recommended SFOT for me, and he recommended Dr. George Mandelaris as seen in my FME installation video.
You know who Dr. Mandelaris is?
No, who's that?
Periodontist in Chicago.
No.
He's probably the GOAT when it comes to SFOT.
I hadn't heard of Dr. George Mandelaris before, so I came home from my FME install and started to do some research on this Dr. George Mandelaris. And it turns out he literally wrote the book on SFOT. So SFOT, it stands for Surgically Facilitated Orthodontic Therapy, and it is closely related to Wilcodontics. Dr. Mandelaris has credited the Wilco brothers as the giants whose backs he stood on for his development of SFOT. My understanding is that the main difference between the two, SFOT, Wilcodontics, is that Wilcodontics was invented just to move teeth faster. It was marketed as cutting treatment time in half. SFOT, on the other hand, its main goal is to regenerate tissues so that they are all healthy, and treatment time being cut in half is a side effect of that. I have included a couple of links down below in the description box of videos that I watched with Dr. Mandelaris that were very, very helpful. Be sure to stay tuned to the end of this segment where I will share my consultation with Dr. Mandelaris. All right, so let's get into Dr. Mandelaris and his consultation. What I really liked about his consultation was I was able to finally see my airway. So he showed me my airway. He also did these cool measurements, which you will see of my face, showing me the angles which are ideal and the angles that I have. So measuring, I think, from my forehead, from my eyes, from my nose, my upper lip. With those measurements, was able to explain how I think I have an elongated midface. If you want a consultation with him, mine was $500. It is expensive in this game, very expensive. I haven't followed up with him yet to discuss insurance and what insurance may or may not cover. I also have not gotten a price from him yet, but I will update you guys once I do. However, I have had a comment that he's pretty darn expensive. He does spend at least an hour and a half with you for your initial consult. He wants to see a CBCT scan. He'll go over that with you. Oh, hi. Did you remember to like and subscribe? Oh, okay, cool. Anyway, here is my consult. It was pretty awesome. I learned a lot about my face. If you look in between my lower incisors, I have a little bit of a hole, and that's from a tongue piercing that I had. And I discovered that when I first started ortho. I've had a couple of gum grafts on my lower front incisors, I think because of the bone loss in that area. But I've had multiple perio consults regarding just that alone. And the majority of experienced providers told me not to touch it because it's hard to graft bone that way. It's a lot easier to go top down, pack it in that way, especially like if you're preparing for implants. So that's been like the general perspective.
I think I understand what they're talking about, but okay.
Especially because it's lingual. I've heard that that's also a little bit harder. Then fast forward to me getting expansion and then working with Dr. Nuaz. He noticed, along with another doctor, that I had bone loss behind my top front incisors now. And he recommended you for SFOT bone grafting, and that's where that puts me today. So after I made my appointment with you, I looked you up and watched a couple podcasts with you where you explained kind of your journey and what your SFOT is. I thought it was really cool that you wrote a whole ass book on SFOT. So it seems like you have a different approach. Because when I talked to my local periodontist about bone grafting, that area, he commented on the Wilkinson method. What's it called?
Wilcodontics.
Yeah, and he said that's what he thought I was referring to when I said...
That is what you were referring to.
Okay, and so he was like, I'm not entirely sure that I would recommend that for you at this time. So that's sort of like, in a nutshell, where we're at.
I don't think there's like a lot of people that do this that have a lot of experience with it. I would say there's probably 3 of us in the country that probably do a lot of this.
Okay.
But you do have some really concerning bone. I don't want to say like bone loss. It's not necessarily like bone loss, like a disease-based process.
Right.
The way in which the teeth are being moved to couple so that they fit properly. Like you have very limited bone here on the inside, on the upper incisors, and on the lower incisors. You can see on the front of the tooth, you've got very good bone support.
Yeah.
That's excellent, Taylor. And I would say to an extent here on the lower, it's very thin, but it's a little bit vulnerable. It's somewhat intact. You have kind of normal human anatomy, but as the tooth is moving back, it's moving out of the bone and there is no more real estate to move the tooth.
Right.
This is highly at risk for gingival recession.
Right.
I'm not telling you that is 100% going to happen, but the problem historically is that the profession looks at this problem as using gum recession as being the barometer of should we do something, should we not do something?
Right.
Do we need to fix the patient? Do we not need to fix the patient? And that is a consequence of the bone being lost, in this particular case, orthodontically, because they're trying to move the tooth into a position that meets your airway for your bite, for your speech, for your function, that type of thing. But they're running out of real estate. And if we only look at gingival recession as being, the barometer of is there a problem or not, because now the gum is receding, that's kind of like after the fact.
Right.
Whereas if we can get out ahead of it and build the bone in, here, that would be a much stronger position to support health for the patient and also to provide an environment with which the orthodontist has more room to move the teeth safely.
Yeah.
And because they don't want to move your teeth out of the bone. It's the last thing the orthodontists want to do. But you're lucky that you're working with somebody like Dr. Nuaz, who's very in tune. I mean, he's also a radiologist, as you know.
Yeah.
He's in tune with imaging and he knows kind of like where the limits are. And so I do think that you have an environment where this could be grafted. I think it'd be very predictable. You have very good soft tissue covering over most of the root surfaces here, which is very favorable. And this, in my estimation, is highly predictable bone regeneration or bone augmentation surgery. Now, it's not nothing. It's not as easy as taking a tooth out and putting a bone graft in a tooth socket. It requires a little more finesse. It's a more extensive of a procedure so that it heals properly and comfortably for the patient. So even though you may only need bone grafting here, the surgery is generally all the way around because you want the gum tissue to kind of be passively removed, passively put back. And if you work through like a little peephole, you can stretch the tissue, you can tear the tissue. There could be negative consequences in how that's all going to heal properly.
Okay.
So it is a little bigger event, but done under the right circumstances, it should be really a predictable and comfortable, relatively comfortable experience for the patient. So my estimation here, you would highly benefit from some bone augmentation in the lower arch.
Okay. Lingual.
Yep.
Okay.
I mean, I would probably if you were open to it, I would like to probably add a little on the buccal as well.
Okay.
Because it'll give you circumferentially, it'll give you more volume all the way around the tooth, and it will give Dr. Nuaz more real estate to protect as he's got more freedom to move the tooth. On the upper arch, clearly you do not necessarily need bone on the front. You've got plenty of bone there, but on the back side, it's getting quite thin. The problem is me going in and doing anything now with this appliance being in place. I don't really have access to do that.
Okay.
I think we would have to talk to Dr. Nuaz, who I've worked with a lot, and we could do something, but I guess I'd want to have a conversation with him. Could we postpone the bone grafting until this FME has been, the bone is consolidated and it's out?
Right.
But maybe just before we start the active tooth movement, because now I have more access to provide a better result for you. Whereas here, I'm going to be kind of working in cramped quarters. SFOT, Orthodontics, it goes by lots of different names. These are all semantics. I mean, basically, at the end of the day, this is a procedure that is aimed at developing what we call the bone morphotype, or improving the periodontal phenotype in a patient who has vulnerability or deficiencies, and they're at higher risk for having iatrogenic, meaning like operator-induced gum recession, bone loss, secondary to orthodontic tooth movement. and so forth. I think this would be a very beneficial procedure for you. I think it'd be highly valuable, and it would be something that would be very long lasting. In order to do that, we have to lift the gum tissue. We have to see the regional anatomy, and then we basically make little perforations between the teeth and then add a bone graft. A bone graft is artificial. It's a little bit of a misnomer. It's not really artificial. It's cadaver bone graft, but that does reorganize and become your own bone over time. So if I was to go back in 2 to 3, 4, 5 years, open a gum and kind of see, what happened to the bone graft that I put in here all those years ago? Hopefully which we wouldn't do unless we were doing another textbook or something. But what we would show is, hey, this bone graft became a part of the patient's own regional anatomy. It became a living construct supporting periodontal and bone health in the jaws and protecting against gum recession and giving more room for the orthodontist to optimally put the teeth without having any consequences. So they can align the teeth up correct, so they come together more ideally, rather than camouflaging a problem or compromising the position of the teeth. When we do that, because we create these little perforations between the tooth roots, we're doing that because we want the blood vessels from within the bone marrow to come out of the marrow and vascularize to that bone graft, so it turns over and becomes your own bone. And that heals through a process called creeping substitution. That's a normal kind of bone grafting kind of outcome.
Okay.
And if there's root surfaces that are totally dehisced, where I can see the tooth root, but it's not really like where you haven't had gum recession or there's not tartar on the root surface, so it's not diseased, it's just devoid of bone. What we're trying to do is regenerate bone there and mimic a periodontal attachment. So we're trying to get a ligament, bone, cementum. So these are principles of what we call guided tissue regeneration at a dehisced root surface, so that we have a functional periodontal kind of organ system that is optimized for orthodontic tooth movement. Because of that whole experience and because of that whole process, the bone reacts to the quote unquote trauma. It's not really trauma like you broke your leg or something, but the physiologic wound healing process is very similar in the sense that the bone that surrounds the tooth becomes demineralized. So it undergoes this what's called a regional acceleratory phenomena. And basically what happens is the bone becomes a little bit rubbery. You won't know that, but it loses some of the mineral content. If you happen to have braces on somebody's teeth and this phenomena is happening, well, now the teeth move without all the resistance to tooth movement because the mineral content has gone down.
Right.
So you can move the tooth more freely and more expeditiously, more quickly. And that was the whole touting of Wilcodontics in the 90s was, we can move teeth so fast, but nobody cares moving teeth fast. I mean, nobody wants to be in braces for 2 to 4 years. We know that, but we're not trying to promote this because we can move people's teeth fast. Adults appreciate the expedited treatment time, but really what we're trying to do is to improve the periodontal architecture and take the patient from being vulnerable to being less vulnerable to not vulnerable, and optimize the anatomy so that the teeth can be positioned perfectly for function, aesthetics, or perhaps orthodontic surgery if the end goal is to move them so that they can really fit properly. If the jaws are being moved forward, it can complement orthodontic surgery very well. At the end of about 3 months, maybe 4 months, the bone that had demineralized now remineralizes, and it goes right back to where it was before. So there's no loss of bone volume, mass, density, anything like that, and that has been studied and published. So it's, as a result of doing the procedure, there's an added benefit that the orthodontist can use to move teeth, yes, faster, but also without all the resistance. So they can move the teeth a little more predictably. The teeth track a little bit better. Because the bone mineral content is kind of reduced, when you start to move a tooth like this into like really hard, dense cortical bone, like you see here, this white bone, sometimes the teeth can be a little more prone to root resorption. The roots can resorb. And because this would be without all the mineral content, the teeth can move now without necessarily the same likelihood that they will resorb. And if you have a patient with lots of crowding, they need to, correct that. Well, those teeth are a little bit at risk for relapse. In other words, like a rubber band effect, the teeth kind of want to go back. But because surgery has been done, the fibers all kind of reorganized now. And so the chance of having this relapse potential is also reduced as well. So there's a myriad of kind of benefits, but the main one is to address this kind of human condition that we all deal with, which is, we have kind of thin thin bone around our teeth. And people that have thinner bone are people that have like what we call a high angle mandible like you. So what I mean by that is if you look at this, this is your interincisal angle relationship.
Okay.
It's about 141 degrees. Ideally, that should be 130. That's not that bad.
Okay.
But I'm going to show you this, which is your mandibular plane angle. So take the incisor like that. Okay. And that's 75 degrees. So that's high. And from sella to nasion in your angle like this is kind of how you've grown. Your ideal is around 33, something like that, plus or minus 5 degrees. So you're around 40, 45 degrees, which means your growth, you've been more vertical in how your structures have grown.
Yeah, I have a longer face.
Yeah. And so those patients that grow with a vertical tendency have thin bone around their teeth. They have more bone is thinner around their teeth, and they're more vulnerable for these consequences. And so these are the patients that are the harder orthodontic patients to treat. They're probably a little bit more at risk for airway problems and TMD problems, and they're also a little bit more at risk for having some periodontal consequences of moving the teeth. People that are doing this stuff well and meaningfully are private practice clinicians like myself. And there are probably a few of us in the country that have done a lot that can stand on all their case reports and the gravitas, like I'm kind of trying to impose here in terms of like this can be done and this is predictable and you would highly benefit from it. That's why you have to go to New York to get your FME. And you can't just get it at your local community orthodontist.
Yeah.
So the skill set is kind of more limited. It's not really a recognized subspecialty, but that's kind of where we're going.
Question about SFOT. So is SFOT originally just meant to quicken orthodontics and it didn't involve the bone grafting, or was it always a bone grafting procedure?
It was generally always a bone grafting procedure. I'm just going to kind of show you some of these angles. Yeah, so it was always kind of a bone graft. The corticotomy procedure, this whole concept has actually been around for a crazy amount of years, but it never really got popularized until like the early 2000s when the Wilcodontics, which were a periodontist orthodontic brother team in Erie, Pennsylvania, popularized this, and they showed the science and they showed as best they could through clinical cases the outcomes, but they were always focused on what I think they heard from patients all the time, which was like, oh, it just takes so long to do my braces, right? It takes 2 years. And so they found that because the bone is demineralized, hey, the teeth move fast. So maybe people would like to use this technique because they move teeth fast. And they also, in those days, weren't really working with the kind of technology that we have here either. They weren't working with the 3D simulations and all the things that we have at our fingertips. They were working with two-dimensional x-rays. And so they kind of missed the point of we can change the bone morphotype. We can change the bone very successfully and very meaningfully. And that was the message that kind of got lost. It got really meant for one that was more on like we can get patients in and out of braces faster. And, the dental world kind of like really poo-pooed that because that wasn't something seen as biologically valuable or anything that way. And there weren't, subsequent to that time, myself and Todd Shire, another colleague of mine in Houston, we've done a lot of work in putting a lot of this in the literature, basically having the American Academy of Periodontology recognize this and start to put some evidence out there with best evidence consensus papers that we've been on and ran to show, hey, there's a lot of research that we can use to like a patchwork quilt to show these different modalities are all being used for this type of a procedure. And it is very valued and is very valid.
So you're saying it's predictable. Is there a time that you've seen where you peel back the gums and you do the corticotomy and then you do the grafting and then it fails or it makes things worse?
So very, very rarely. However, I will tell you in, 600 cases, I've done a lot of these cases. I will tell you that the biggest risk would be infection. Now, infection is very rare. It does not happen often, particularly in a younger individual like yourself, who's otherwise systemically pretty healthy. That's pretty rare, but it has happened. And in those cases, I've had to remove the bone graft entirely and start over. In some cases, patients have lost bone around their teeth, but Taylor, I could count on almost one hand how often that has happened. It's not all that. And somebody that is very experienced and does this a smooth operator with this type of technique, has excellent staff support and anesthesia support. It's not a very common phenomena, but it can happen. I'm
Okay.
not saying it can't happen. It can. So we treat the patient with sterile drape, antibiotics before the surgery or in the IV at the time of the surgery, post-operatively, frequent plaque control afterwards, and meticulous surgical therapies and technique. So there's a lot that goes into it, but I think with the level of care and expertise that we provide, it's not a high risk.
Okay. And I asked that question because when it comes to my lower incisors, that has been the number one concern that's been brought up is when you do that bone grafting, you have to essentially destroy the bone in the area, right, to get it to take.
No, you do not, because you almost have no bone to destroy.
Right. So how will it?
There is no bone here. It's completely dehisced.
Right.
When I open a flap, there's going to be tooth roots. I'm looking at tooth roots.
Wow.
So basically, we perforate in between to get the blood supply.
Okay.
And we'll layer the bone graft there.
Okay.
And if I was doing your front tooth, if you said the orthodontist wants to take this front tooth and move it this way. Right? Yes, I would have to decorticate this bone to create that demineralized matrix so we can move the tooth this way. Yes, but there's nothing to decorticate here.
Okay.
There isn't any. That's what I'm saying. It's almost like a complete regeneration phenomena here for your lower incisors.
Right.
And for here, you can see this tooth root. There's no bone there.
I see. But so bone will still take and grow in that area even if there's no bone at all?
Yes, because it's coming from the bone in between the interproximal bone and the overlying gum, which has periosteum in it, which has blood supply. And you do not have a diseased root surface.
Okay.
So it makes it even more predictable. You haven't had like a disease insult here where you've got tartar and calculus and periodontal infection.
I'm going to let you explain what you wrote or what you drew up on my skull.
So this is just the vertical growth pattern.
Okay.
Just showing kind of like how you grew. This is 42 degrees. This is your incisor angle at 100 degrees. So that's, I don't know, it's probably, it's 100. It's pretty close to being ideal.
Okay.
This is your mandibular plane angle. That's 70, or your lower incisor to the mandibular plane angle. So your incisor angle, that's 75 degrees. That is, let me see. Yeah, that's a little bit. Usually that should be more like at 90 degrees. You just have a high mandibular plane angle, and then this is the interincisal angle relationship and what we call the SNA angle, SNB angle. So it just shows this 83 is pretty normal. SNB is like 78. That's probably a little bit on the retrusive side, but not terribly out of. And then in terms of facial height, this is from the forehead to the base of the nose, and then from the base of the nose to the base of the chin. So your face is kind of
recessed.
You have a little, a little bit. It is recessed, but you do have a little bit. I would say your facial proportions. You have a little bit of a longer lower face height than you do mid face. So this, ideally, should be like a third, a third, a third. And so your mid face is a little bit shorter than your lower face height.
Interesting.
You probably have a little bit of what we call vertical maxillary excess.
Vertical maxillary excess.
Excess.
Yeah, I've only recently invited the idea of jaw surgery. It's the thing that I've been trying to avoid since braces, and I'm learning so much. Like you just doing this, I've never seen this done before.
If you have an airway issues, because you do have a lot of very positive findings on your airway intake forms, a lot of significant findings.
Positive meaning like
all those yeses that you checked off on the airway forms you sent in.
Yeah.
And your airway, we don't treat a static X-ray. I wouldn't say, you have an airway problem because your airway volume looks small, but it is a little bit constricted here. You can see anterior posterior, it's a little bit narrowed. Probably you'd benefit from a sleep study or some sort of home sleep study or some kind of screening that would kind of determine, is there anything going on here or not, particularly with all the positive signs that you had on the imaging intake forms. With that, if you do have a sleep apnea problem, jaw surgery should be considered. You shouldn't just discount it because it could open up your airway and really have a very positive influence on your systemic health.
Okay, so it sounds like what you're suggesting is do the whole lingual bottom side.
Buccal and lingual.
For the lower jaw.
All right.
And then for the upper jaw, we're waiting until FME is complete. We take that out. And then you're recommending at this time just the lingual.
Probably so, yes.
Okay.
Probably so.
And the whole angle, not just the section of the incisors.
Probably so.
Okay.
Remember, on the lingual, it's all attached gingiva, so you don't have there's not always the same risk of you having gum recession. That's not likely to happen. If you do have any kind of, if these are all dehisced and you don't have really any bone support around the teeth, that could potentially put you at higher risk for having, a periodontal problem down the road.
If you do SFOT or just in general?
If you do not do anything.
I see.
Yeah, it's always better, even though you may not have any gum recession, particularly on the inside, because it's all attached gingiva. This is very resilient, strong, hard gum tissue.
I see.
It's always better to have a regeneration, like a periodontal regeneration. It's always better to have like ligament, bone, cementum, like a nut and bolt type of approach, rather than have like a zipper. And right now, this could be like a zipper where, something gets in there, you could have more rapid, what we call attachment loss around the teeth.
Yeah, that makes sense to me just because of my struggle with my lower incisors, the gum grafting, because I've had 3 now.
Right, it doesn't maintain as well.
Correct. Yeah. And then I learned that the receded gums actually came from the bone loss that I didn't know I had.
Exactly.
And once I found that missing piece, it all made sense. So what you're saying makes perfect sense.
Yeah.
Like it almost feels like it's a matter of time before I start having gum issues because there's no support for the gum.
You just don't know, right? And I don't have a crystal ball. I can't tell you what's going to happen in your future, but all I can tell you is the risk is elevated. That's all. So if you decided to do nothing, frequent maintenance would be key, and there's a limit to what Dr. Nuaz can do.
Right.
And that you just have to kind of accept that compromise and deal with something if it came up. Instead of being proactive, you're going to have to be a little more retroactive.
Yeah, I gotcha. So I also know that my teeth have dropped down a bit while doing expansion. So intrusion.
That'd be more facilitated with the SFOT as well.
With a little less possibility of root resorption. Is that correct?
Exactly, Taylor.
Okay. And then that's awesome to hear because I know that's one of the main risks. For the front incisors, intruding them up, it's not going to give me more bone behind that area. I'm still lacking bone in that area, correct?
It's not going to give you...
It's not going to push it back up into bone. It's just there's no bone there.
Exactly.
Okay. Because I see it.
Yeah, it's not going to give you more... It's not going to give you more bone. The topography will basically follow the tooth more or less.
It looks like what's holding my front teeth in place is that front bone and then the roots at the top.
And the sides. And the bone.
Oh, yeah, that's right. Okay.
You don't see, You can't... This is a different type of imaging center, so I don't really see... You can't see this very well, but there's bone in the, on the sides and the front. So like 270 degrees, you have bone all the way around the tooth. 90% you don't, right? So 270 around, you have bone, 90 degrees. Not quite as much.
So it sounds like the risk is relatively low as far as it not taking. You're saying that it's pretty predictable in your practice.
I think in my practice, in your type of case, with your type of anatomy, with your type of health history, with your gingival kind of
at the front door.
Yes. For you, I think it'd be quite predictable.
Okay, that's very helpful. Girls on! How's my gap looking though?